cardiomyopathy. It is one of the common causes of heart failure in pregnancy and a significant contributor to maternal mortality and morbidity. It is my pleasure this morning to introduce Dr. Mnguni. She'll talk us through this diagnosis and how we should actually make an acute diagnosis and manage these patients. Thank you.
Morning, everyone. I'm Dr. Mnguni. I'm presenting peripartum cardiomyopathy. My supervisor is Dr. Kumar. So today we'll go through the definition, epidemiology, pathophysiology, clinical presentation, diagnosis, management, prognosis, and counseling of patients with peripartum cardiomyopathy. Peripartum cardiomyopathy is a rare but potentially life-threatening cause of heart failure in obstetrics. An important cause of maternal and neonatal mortality and morbidity worldwide. Early recognition can be difficult as symptoms mimic normal pregnancy. The natural history and etiology of this disorder is not fully understood. In the past decade, there has been an increase in the knowledge about epidemiology, pathophysiology, and genetics in peripartum cardiomyopathy. So there has been different definitions over the years, and there has been changes based on scientific knowledge. So the current definition that we are using is from Busachs and colleagues in the European Society of Cardiology in their paper in 2019. So they have simplified the definition into three criteria. The first criteria is heart failure secondary to left ventricular systolic dysfunction with the left ventricular ejection fraction of below or equals to 45%. Second criteria is occurrence towards the end of pregnancy or in the months following delivery. And the third criteria is that there must be no other identifiable cause of heart failure. Currently, clinicians and researchers worldwide currently use the European Society of Cardiology 2019 simplified case definition. So this definition was simplified for us to have a quicker diagnosis of peripartum cardiomyopathy, which enables us to have an diagnosis and early management of these patients, therefore reducing the fetal maternal morbidity and mortality. So with the epidemiology, peripartum cardiomyopathy is a universal condition that is of unknown true incidence and prevalence. Variable incidence worldwide is currently estimated to be around 1:2,000 live births. In South Africa, its epidemiology is the incidence is estimated to be between 1,000 to 3,000 live births. In a study that was done between 2011 and 2014 in South Africa by Siguke and colleagues reported an incidence of 1:1,000 live births. And the incidence in Nigeria is noted to be the highest, which is 1:100 live births in Nigeria. And in a study that was conducted, it was noted that the reason for this high incidence in Nigeria was due to the moms that are post-delivery, they would sleep on the beds that had hot mud, were made of hot mud, and they were consuming the high salt pork, which predisposed them into peripartum cardiomyopathy. Was also in Nigeria, they noted that when they did the echoes on these patients, they actually had a normal ejection fraction. So left ventricular ejection, it is more studies are still needed to confirm this. In Haiti, their epidemiology is up to 1:300 live births. In Japan, the incidence is the lowest, which is 1:20,000 live births. The prevalence is noted to be higher in African populations, older and multiparous women. The maternal mortality is between 5 to 20%, depending on the setting of where your patient is on their geographic. So this is just a geographic representation of the epidemiology. I think there was an error in this image. Nigeria is supposed to be 1:200, and Haiti is 1:300 live births, and in South Africa is 1:1,000. So these are the physiological cardiovascular changes in pregnancy. So in pregnancy, from the second trimester, there's an increase in the plasma volume from between 40 to 50%. There's an increase in cardiac output by 30 to 40%. There's an increase in the heart rate. There's decrease in the systematic vascular resistance. And sorry. So then during delivery, the cardiac output increases further by 50%, and immediately following delivery, 70% of the cardiac output it increase over the preload values. The cardiac output returns to the pre-labor values by 1 hour following delivery and to the pre-pregnancy level by another 4 weeks post-delivery. So all these changes, they do play a role in the development of peripartum cardiomyopathy, as some of the signs and symptoms of peripartum cardiomyopathy may mimic the symptoms of pregnancy. So the risk factors for peripartum cardiomyopathy, it is quite multifactorial, but there has been maternal factors, pregnancy factors, and other factors that have been identified for peripartum cardiomyopathy. So maternal factors, age is one of the factors. Peripartum cardiomyopathy is prevalent across all age groups, from the extremes of age below 20 and up to more than 35 years of age. And multiparity, ethnicity, patients of African ancestry have been identified to be one of the risk factors for peripartum cardiomyopathy and obesity. Pregnancy factors, multiple pregnancy, hypertensive disorders, and preeclampsia is associated with peripartum cardiomyopathy. And other factors include genetic predisposition, which is about 15% of the patients with peripartum cardiomyopathy. They possess a TTN gene mutation on the studies that have been done. Nutritional deficiencies such as selenium deficiency is associated with peripartum cardiomyopathy, prolonged tocolysis, and geographical location of the patients, which we have mentioned. The exact pathophysiology, the exact etiopathophysiciology of peripartum cardiomyopathy is currently unknown, but there have been proposed mechanisms that have been brought across to explain why we have patients with peripartum cardiomyopathy. So one of the proposed mechanisms is the prolactin cleavage hypothesis, which is commonly mentioned as the two-hit hypothesis. So the two-hit hypothesis, it suggests that a genetically susceptible individual, they are the ones that have the TTN gene mutations. If they're exposed to multiple insults to the myocardium before or during pregnancy, this may trigger an inflammatory response during pregnancy and postpartum, leading to the impairment of myocardial infarction. But we are still going to go through the two-hit model hypothesis in the following slides. And there is also the other model that has been proposed is the vascular model. So the vascular model of peripartum cardiomyopathy, it actually focuses on the cardiac function's inability to adapt to the hemodynamic changes and stressors that occur during pregnancy and the peripartum period. Then this results in cardiomyocytes release and vasoactive eventually imbalance and vascular dysfunction. Oxidative stress, myocardial inflammation, autoimmune responses, and other known contributing factors is genetic mutations that may share similar genes to dilated cardiomyopathy, anti-angiogenic factors, microvascular dysfunction, and hormonal changes. So with the two-hit model, so it talks about the three factors that are involved with the pathophysiology of patients. It's the genetic factor that is the underlying factor that is there, and there is the vascular and the hormonal model that is involved. So up to 15% of patients with genetic variants associated with the TTN gene mutations. There was a study done by Ware et al. In 2016 where there were 172 women with peripartum cardiomyopathy. 43 women had the gene that was associated with dilated cardiomyopathy. 65% of these, 65% of the mutations occurred in the TTN gene, which encodes for the TTN. So the TTN gene mutants, they were seen in 13% of Black women, white women. So of these patients that had the TTN gene mutation, on the study, they had a lower, on their results, they had a lower left ventricular ejection fraction at 6 months and 12 months. So the TTN gene mutation is noted to be higher in Black women, and this explains the higher incidence and the worst prognosis in Black women, of which we have mentioned that Black ethnicity is one of the risk factors for peripartum cardiomyopathy. Okay, so of note on the study that was done on the TTN gene, it was also noted that of the patients that had the TTN gene, they were without hypertension or preeclampsia, whereas those that had the TTN gene they were able to actually develop hypertension. So this still shows that the genetic factor is not the only factor that is associated with peripartum cardiomyopathy. It is multifactorial. So the first pathway of the two-hit model, so this just explains the image. So, so with the increased oxidative stress during pregnancy, so this reduces the activator of the transcription 3 factor, which is in the cardiomyocytes. So this reduced STAT3, then there is a decreased level of magnesium peroxidate dismutate. This, which is it's a scavenger that removes reactive oxidase species. So this leads to the accumulation of reactive oxidase species. So which then stimulates the secretion of peptidase capsin D from the cardiomyocyte, which is then released into the circulation. So when the capsidin D is in the circulation, as we know in pregnancy and in the peripartum period, we have high levels of prolactin that is produced by the anterior pituitary gland. So the elevated levels of anterior pituitary gland, which is the 23 kilodactyl prolactin, it is then cleaved from 23 kilodactyl prolactin into 16 kilodactyl prolactin by capsidin D. And the 16 kilodactyl prolactin, it is vasculotoxic and it's also cardiotoxic, which then is the one that induces endothelial damage and it impairs cardiomyocytes metabolism, resulting in apoptosis of cardiomyocytes. And this also also upregulates endothelial expression of microRNA that is located in the endothelium, which also causes further cardiomyocytes dysfunction and apoptosis. In a study that was done by Kelfiha Clean in 2007, they did a study on mice, and the mice that had a lower STAT3 expression on the biopsies that were done on the cardiomyocytes, those patients that had those mice that had peripartum cardiomyopathy showed a lower STAT3 expression and they had higher serum levels of 16 DKA prolactin. And those were noted to have peripartum cardiomyopathy. So then that is how they then eventually developed bromocriptine, which we'll talk about later. So in those mice, they were given bromocriptine to block the prolactin from the pituitary gland. This was able to reverse peripartum cardiomyopathy in those mice that had STAT3 gene deficiency. The second pathway of the two-hit model is that the placental expression of the pro-angiogenic factor, which is the vascular endothelial growth factor, is downregulated through two mechanisms. So the vascular endothelial growth factor is pro-angiogenic molecule. So in the peripartum period, the placenta secretes several vasoactive molecules. The secretion of peroxidase proliferator activated receptor gamma 1 alpha core activator is downregulated. Then there is an increase in the production of anti-angiogenic molecule, which is the S-FLT1. So with also inadequate upregulation of vascular endothelial growth factor, this results in the worsening of the angiogenic milieu of the peripartum cardiomyopathy. And of note is that S-FLT1 is also associated with preeclampsia, which is well known. So this is just an image that is showing us the biomarkers that are present in a patient with peripartum cardiomyopathy. And of these biomarkers, we can use them for diagnosis, prognosis, and also monitoring the treatment response of these patients. So the biomarkers that we can use for diagnosis is NT-proBNP, TROP-I and TROP-C, cathepsin D, and adiponectin. And S-FLT1 can be used as well for diagnosis. And for prognosis, it's the NT-proBNP, TROP-I, S-FLT1, microRNA 146, and the rest. And for monitoring the treatment response, whether a patient is improving on the treatment after diagnosing peripartum cardiomyopathy, the biomarker that we can use is NT-proBNP. So clinical presentation of peripartum cardiomyopathy, majority of women, 78% presents in the 4 months after childbirth, 9% in the last month of pregnancy, 13% presents either prior to a month before delivery or 4 months after delivery. Clinical presentation. So the patients present with shortness of breath. So based on your clinical patient and your clinical findings, you have to grade whether they are New York Heart Association 1, 2, or 3. They may present with orthopnea, unexplained cough, particularly when they are lying down, palpitations, dizziness, swelling of the legs. Additionally, there may be abdominal discomfort that is caused by hepatic congestion and precordial pain. Clinical signs on examination, you must look for tachycardia in pregnancies, a heart rate of more than 100 beats per minute. Look for pedal edema, raised JVP, displaced apex beats, S3 gallop, and crackles. Of note, the clinical symptoms and signs mimic the symptoms of pregnancy. So you need to have a high clinical index of suspicion for peripartum cardiomyopathy. So the differential diagnosis for peripartum cardiomyopathy is pre-existing cardiomyopathy, such as maybe dilated cardiomyopathy, but these usually present in the second trimester or earlier on before the last month of pregnancy. Valvular heart disease with mitral stenosis and aortic stenosis being the commonest encountered vascular valvular defects in pregnancy. Preeclampsia with severe features complicated by pulmonary edema. Pulmonary embolism is one of the commonest also differentials for us in patients with that present with symptoms of peripartum cardiomyopathy that we need to rule out, myocarditis and amniotic fluid embolism. So this table shows us the different differential diagnosis and what you should look for that is going to differentiate it from peripartum cardiomyopathy. So with the pre-existing cardiomyopathy that is highlighted in red here, is that the patient will have a history of heart failure prior to pregnancy. In prior echo studies, they will be there and they would have a low left ventricular ejection left ventricular ejection fraction before pregnancy. And also our patient present with preeclampsia. So we also need to rule out if a patient has preeclampsia, and this patient would have a preserved systolic function on the echo. Myocarditis, consider if there is a signs of viral prodrome histological diagnosis and fulminant presentation, but we don't commonly perform histological diagnosis currently in our setting. And pulmonary embolism, especially in those patients that are postpartum, we need to rule out pulmonary embolism. So the investigations, so you have molecular and non-molecular investigations, which is your lab test, are your molecular investigations, FBC, UNE, LFT, and cardiac enzymes, TROP-T and BNP and NT-proBNP, ECG. We're still going to go through them individually, imaging, chest X-ray, and echo. So the inflammatory markers such as CRP and leukocyte count, although they are non-specific for peripartum cardiomyopathy, they are often elevated in peripartum cardiomyopathy. Cardiac enzymes, brain natriuretic peptide, so when it's more than 100, it is suggestive of peripartum cardiomyopathy, and terminal pro-brain natriuretic peptide of more than 300 is suggestive of peripartum cardiomyopathy. TROP-T is a marker of cardiomyocyte injury and is often normal in a normal range in peripartum cardiomyopathy. So this is just a diagram that is showing us in terms of diagnosing peripartum cardiomyopathy in relation to the BNP and the echo. So if you have a patient that is presenting with shortness of breath towards the end of pregnancy or postpartum period, the natriuretic peptide should be done and an echocardiogram, echocardiology, sorry. So the raised natriuretic peptide, that is BNP of more than 100 or the NT-proBNP of more than 300, and an echo finding with an ejection fraction of the left ventricle that is below 45%, then it should consider peripartum cardiomyopathy and involved cardiology. Whereas in the patient with normal BNP of less than 100 and NT-proBNP of less than 300 and an ejection fraction of more than 45%, peripartum cardiomyopathy is unlikely, and consider other non-vascular causes of the presenting symptoms. So with the ECG, there are currently no ECG findings that are specific for peripartum cardiomyopathy. Tibazawa and colleagues reported that more than 90% of patients had non-specific ECG abnormalities that were diagnosed with peripartum cardiomyopathy. The commonest features that were found were sinus tachycardia, non-specific ST segment and T-wave abnormalities, left ventricular hypertrophy with strain pattern, arrhythmia such as atrial fibrillation was one of the findings. Chest X-ray. So chest X-ray is non-specific for peripartum cardiomyopathy. And depending on whether your patient is in the antepartum or postpartum period, as the clinician, you need to decide whether you think this patient needs a chest X-ray and weigh the benefits versus risk to the fetus before you decide on doing the chest X-ray. So the findings that are common for peripartum cardiomyopathy, it is features of cardiac strain such as alveolar shadowing, septal lines, Kelly B lines, cardiomegaly with an increased cardiothoracic ratio, pulmonary edema, pleural effusion. So as I've mentioned, when you have a patient that is still in the antepartum period, you must consider the fetal dose radiation exposure to the fetus for chest X-ray, which is quite small, is 0.01 gamma units, but should be performed if other investigations fail to explain the cause of symptoms. Echocardiography. So transthoracic echocardiography is cheap, it's safe during pregnancy and lactation. It provides real-time cardiac structural and functional assessment necessary to diagnose peripartum cardiomyopathy. So findings or criteria to diagnose peripartum cardiomyopathy, it is left ventricular ejection fraction that is below 45%. There may be or there may not be left ventricular dilatation, which it was part of the definition in the previous part of the diagnosis in the previous definition, but it is not part of the diagnosis in the current definition of peripartum cardiomyopathy. And there will be signs of global hypokinesia. In patients with peripartum cardiomyopathy, they will also have fractional shortening of less than 25%. And you should also look for other features that you may find, such as an intracardiac thrombus. So, however, echocardiography does not only help in making a diagnosis, but it also provides a valuable tool that we can use for prognostic information. In studies which we have seen and we're still going to go through, it has been shown that the initial ejection fraction on diagnosis, it is a prognostic marker for the improvement of peripartum cardiomyopathy post-treatment. So cardiac MRI, cardiovascular magnetic resonance imaging is the gold standard radiation-free modality, but it's not readily available everywhere. Assessing cardiac structure and function and myocardial tissue characterization is one of the factors that are good for the MRI. The main advantage is that cardiac MRI has a higher spatial and temporal resolution, outstanding accuracy, reproducibility, independence from the acoustic shadowing, and higher sensitivity for detecting left ventricular thrombus. Cardiac MRI is an excellent technique for ruling out other de novo heart failure diagnosis in the peripartum period to complete echocardiography, especially in cases where the diagnosis is inconclusive. So administration of gadolinium contrast agent in patients going for cardiac MRI in late gestation, it should be avoided until after delivery. So if you have a mom that is in the antepartum period, so you would not offer them MRI until after they have delivered. So cardiac tomography, its role includes enhancing echocardiography when the diagnosis is unclear, and it is not commonly practiced in our setting. So the benefit is assessing cardiac structure and function, detecting intracardiac and extracardiac complications such as intramural thrombus and pulmonary embolism. Detailed anatomical assessment is also done at cardiac CT scan to actually plan for those patients that are going for surgery, such as cardiac transplant. So nuclear imaging techniques have limited use in diagnosing peripartum cardiomyopathy. They are mainly used to distinguish peripartum cardiomyopathy from ischemic cardiomyopathy. Single photon emission computer tomography, positron emission tomography, and cardiac scintigraphy and myocardial perfusion images. These are not commonly performed in our setting. So ventilation perfusion scan. So the ventilation perfusion scan is particularly useful in identifying or ruling out pulmonary embolism. VQ scans involve lower radiation exposure compared to CTPA, making them safer. However, it is important to note that even low doses of radiation exposure can be concerning, especially during pregnancy. So we commonly use the VQ scan as well to rule out or to make a diagnosis of pulmonary embolism if we are unsure of the diagnosis. Endomyocardial biopsy. It is only indicated if there is suspicion for an alternative diagnosis, such as giant cell myocarditis, that would necessitate a different management plan. Endomyocardial biopsy is not routinely used to make a diagnosis of peripartum cardiomyopathy unless a cardiac transplant is considered and we are unsure of the diagnosis. It is useful when myocarditis and other rare metabolic or storage cardiomyocyte diseases are suspected. Biopsy is sent for DNA extracts for viral assays and autoantibody assays. So we'll move on to management of peripartum cardiomyopathy. So with the patient, when they present to you, you have to differentiate whether they're antepartum or postpartum and assess whether are they hemodynamically stable versus hemodynamically unstable. So clinical management of peripartum cardiomyopathy is a daunting task without specific and evidence-based data. The therapeutic strategy, it mirrors other forms of heart failure with left ventricular systolic dysfunction. Apart from bromocriptine, there are no other treatments specific for peripartum cardiomyopathy that are currently in use. So it requires a multidisciplinary approach, which is important, and this necessitates a concrete inputs from other disciplines. So which involves the obstetricians, you need to involve the physicians or the cardiologist if they are available, intensivist, anesthesiologist, neonatologist, nurses, and cardiac surgeons. So the initial therapy of patients with acute peripartum cardiomyopathy is centered around the following principles. So we need to optimize the preload, and give adequate oxygenation, circulatory support, reduce the afterload, treat inexperienced tertiary units. So if a patient is in a district hospital, they need to be referred to the tertiary institution. Offer bromocriptine, diuretics, vasodilated if the blood pressure allows, cardioselective beta blockers, inotropic support, ICU admission in severe cases. So your management will be tailored according to how severe the peripartum cardiomyopathy is and presentation. So with the afterload, so the afterload is the pressure that the left ventricle must overcome to circulate blood to the system, to the systemic circulation. So the diuretics, they decrease the afterload. So in terms of obstetric management, it is a multidisciplinary care. Timing and mode of delivery is based on maternal stability and cardiovascular status. You must avoid multiple and high boluses of oxytocin. Concentrated oxytocin for postpartum hemorrhage prophylaxis must be given to avoid fluid overload. So this is a patient, so when you have a patient that is unstable with severe peripartum cardiomyopathy. So cardiopulmonary distress is defined as hemodynamic instability with a systolic blood pressure that is below 90 millimeters of mercury, a pulse rate of more than 130 beats per minute or below 45 beats per minute. So a patient that has a tachycardia or a bradycardia. Respiratory distress is a respiratory rate of more than 25 beats per minute or peripheral oxygen saturation of less than 90%. Signs of tissue hypoperfusion and abnormal cellular oxygen metabolism. These are found from an increased lactate of more than 2, a low central venous oxygenation of less than 60, altered state, which is a low GCS, patient with a cold, clammy, and motile skin, and an oliguria of less than 0.5 ml per kg per hour. So then how do you manage a patient that presents hemodynamically unstable? So you restrict their fluids, and you nurse the patient in an upright or 45 degrees position. You offer oxygen depending on their oxygen saturation. You will decide whether they need a face mask oxygen or they need intubation, invasive intubation or nasal prongs, depending on the clinical picture of your patient. And then you offer inotropes if your patient requires inotropic support. Diuretics, so we give furosemide or thiazide. These, they reduce the preload by causing vasodilation. By excreting the fluid from the kidneys. We offer beta blockers, and the safer beta blocker that we offer, it is metoprolol. Vasodilated, you offer nitrates and hydralazine, and these reduce the afterload. And this is a multidisciplinary team management, so you need to also consult your anesthetist if needed, ICU, especially since this patient is hemodynamically unstable, and your internal medicine. And if a patient is still in the antenatal period, then you plan for delivery, but also in consultation with your MDT and looking at the clinical picture of the patient. But a hemodynamically unstable patient with peripartum cardiomyopathy is an indication for delivery. So this is a diagram from the European Journal of Heart Failure in 2019. So with the red, we look at the red, it's showing us the severe patient with peripartum cardiomyopathy. So these patients presented cardiogenic shock, hemodynamic instability, and respiratory insufficiency. The ECG will show non-specific changes and often a tachycardia. Chest X-ray will show signs of pulmonary congestion, enlarged cardiac silhouette, and pleural effusion. And the natriuretic peptides are elevated. So when the patient has an echo, these patients with severe peripartum cardiomyopathy have a left ventricular ejection fraction of less than 25%, right ventricular dysfunction, and they may or may not have dilatation of the left ventricle. And these patients, how you manage them, you inform ICU, offer diuretic therapy IV, inotropic support if needed, invasive ventilation, mechanical circulatory support, and consider bromocriptine for 8 weeks in these patients, and also oral heart failure drugs after they have stabilized. So this is a diagram showing us how to manage a patient with acute heart failure in pregnancy. So it's just quite a lot to go through, but it gives us quite an easy reference when you are especially in an acute setting and you're not sure what to do. So if you have to confirm the diagnosis, you've done an ECG, blood test, chest X-ray, and an echo. In an antenatal period, you can offer antenatal corticosteroids for fetal lung maturity, and also consider for women between 23 weeks and 23 weeks of gestation, and also plan for transfer to a tertiary institution. And then you must have an MDT meeting that is going to include the obstetrician, cardiologist, neonatologist, anesthetist, and intensivist, and assess the heart failure, whether it's mild, moderate, or severe, and then manage according to the severity of the heart failure. So these are just the drugs. It just mentions which drugs we use antenatally and which drugs to use postnatally. So in antenatal period, beta blockers are safe to use, loop diuretics, vasodilators, which is hydralazine and nitrites, postnatally ACE inhibitors, angiotensin receptor blockers, beta blockers, spironolactone, and diuretics are safe to use. So mechanical circulatory support is indicated in patients with no improvement in circulatory stability despite optimal treatment. So this is when you consult your patients with ICU and offer invasive ventilation and inotropic support. So bromocriptine. So bromocriptine in these patients, we use a dose of 2.5 milligram once daily for at least 1 week. And this is advised in uncomplicated cases. Extended treatment is 2.5 milligram twice daily for 2 weeks, and then 2.5 milligram once daily for 6 weeks, and is advised when the ejection fraction is less than 25% with or without cardiogenic shock. Of note is that bromocriptine, it is prothrombotic, so these patients need to be on the on prophylactic Clexane. So this is a patient, if you have a patient with stable peripartum cardiomyopathy. So Boussachis and colleagues recommended the BORD scheme therapeutic approach, which includes bromocriptine, oxygenation, anticoagulation, relaxants, diuretics. And we also offer these patients beta blockers, ACE inhibitors, angiotensin receptor blockers are contraindicated in pregnancy. So if they are pregnant, we should not give these drugs. But if they, and then we offer hydralazine in combination with nitrites. No data currently exists for direct oral anticoagulants in pregnancy. So this is a schematic diagram of the board scheme from the European Journal of Heart Failure in 2019. So we offer bromocriptine, dose according to the severity of the disease, oral heart failure drugs, anticoagulation, prophylactic dose, relaxants, which is your IV vasodilated if the systolic blood pressure is more than 100, and diuretics in case of fluid overload. So this bottom part here tells us about the dose of bromocriptine. So if your patient has a left ventricular ejection fraction of more than 25%, no cardiogenic shock, and no ICU treatment, you offer bromocriptine 2.5 milligram once daily for 7 days as at least prophylactic, and also offer them at least prophylactic anticoagulation. In a patient with a left ventricular ejection fraction of less than 25% and or right ventricular dysfunction and or cardiogenic shock and or ICU treatment, you offer them bromocriptine 2.5 milligram BID for 14 days, which is bi-daily, followed by bromocriptine 2.5 milligram once daily for 42 days, and also offer prophylactic anticoagulation during that time being. And patients with severe peripartum cardiomyopathy that require ICU in cardiogenic shock with ventilation. So you need to start them on the bromocriptine 2.5 bi-daily and uptitrate to a maximum of 10 to 20 milligram daily, depending on their levels of serum prolactin levels, until successful suppression, and also offer them anticoagulation. So this table here is just showing us which drugs are safe to use in pregnancy and which ones are safe to use during lactation. So with the beta blockers, they are safe to use in pregnancy and also during lactation, and they're essential for all patients, and we need to continue them for at least up to 12 months. ACE inhibitors we need to avoid in pregnancy. They are safe to use in the postpartum and lactation and continue for 12 months. And diuretics and the thiazides are safe to use in pregnancy and postpartum, and we need to discontinue them as soon as symptom control is achieved, such as edema has improved and congestion has improved. And vasodilators, they are safe to use in pregnancy and also during lactation, and we need to discontinue them once the patients are asymptomatic. So this is also just an image of the medication that we can use in pregnancy: anticoagulation, in pregnancy, low molecular weight heparin, beta blockers, metoprolol, diuretics. It is furosemide or HCTZ that we can use in pregnancy. So bromocriptine is a dopamine agonist that blocks prolactin production. The drug is recommended in peripartum cardiomyopathy patients with severe left ventricular systolic dysfunction or those unwilling to breastfeed. Based on the evidence from recent studies, the European Society of Cardiology heart failure guidelines recommend adding bromocriptine to treat acute peripartum cardiomyopathy, especially in severe cases. But however, the American Heart Association guidelines, they currently do not approve the use of bromocriptine because they say that it is currently not FDA approved. So patients taking bromocriptine are advised to use preventative anticoagulation because bromocriptine is prothrombotic. So there is a currently ongoing rebirth trial for bromocriptine. Because there hasn't been many studies that have been done on bromocriptine. So the ongoing rebirth trial involves 200 women with newly diagnosed peripartum cardiomyopathy with an ejection fraction of less or equal to 35%. It is a randomized to placebo controlled trial of bromocriptine, 2.5 milligram BD for 2 weeks and 2.5 daily for 6 weeks. So the bromocriptine group will be on the prophylactic anticoagulation rivaroxaban 10 milligram daily for 6 weeks. So this wants to evaluate the impact of bromocriptine on myocardial recovery and the clinical outcomes on these patients that were on bromocriptine versus the ones that are not on bromocriptine. Of note is that they will also be assessing the biomarkers of these patients with peripartum cardiomyopathy, including the 23 kilodactyl and the 16 kilodactyl prolactin, and MR 146 will also be assessed. So the newer modalities of targeted therapy, there are currently new biomarker-based therapies. So biomarkers that are associated with peripartum cardiomyopathy, they may serve as a potential target for newer therapies to manage peripartum cardiomyopathy, since the only targeted therapy that we have for peripartum cardiomyopathy is bromocriptine. So currently there is an miRNA 146A. It regulates inflammation and immune responses. There is potential improvement in cardiac function. However, studies on STAT3 KCO mice have demonstrated that despite improvement in left ventricular function, the left ventricle still remains dilated while these patients are on treatment. Vascular endothelial growth factor analogs. So vascular endothelial growth factor modified RNA encoding was useful for the induction of therapeutic revascularization of the heart. In preclinical studies, it has been shown to regulate endothelial cells and cardiomyocyte survival and proliferation. Pro-angiogenic therapy with recombinant vascular endothelial growth factor was found to improve peripartum cardiomyopathy. Adiponectin. So adiponectin, it holds a pleiotropic metabolic effects, including potential benefits of cardiovascular health. Research is ongoing regarding its use and its therapeutic targets of peripartum cardiomyopathy. Perhexilin is a glucose uptake enhancing drug, is found to decrease cardiotoxic side effects in mice. The cardioprotective property of this drug appears to be promising in patients with peripartum cardiomyopathy and that have peripartum cardiogenic shock. Pentoxifylline is it has anti-inflammatory properties. It prevents inflammation that is associated with peripartum cardiomyopathy. There is also ivabradine, which is a drug that reduces the heart rate through selective inhibition of funny current in the sinoatrial node. And its potential benefits is that it reduces the workload of the heart and improvement of the cardiac function. Anticoagulation in peripartum cardiomyopathy, the overall venous thromboembolism rate within peripartum cardiomyopathy population is as high as 2.2 to 6.8%. In the Cott et al. 2014 thromboembolism was the most common complication in patients with peripartum cardiomyopathy. American Heart Association guidelines on dilated cardiomyopathy in 2016 advised on anticoagulation in women with peripartum cardiomyopathy at a left ventricular ejection fraction of less than 30%. But the European Society of Cardiology in 2019, their criteria was an ejection fraction of less or equal to 35%. And they also advised bromocriptine in these patients that have an ejection fraction of less than 30 or 35%, and patients that are on bromocriptine should be on anticoagulation. And starting anticoagulation from late pregnancy up to 8 weeks postpartum is advised. So in pregnancy, we offer these patients low molecular weight heparin or unfractioned heparin. In postpartum period, warfarin is safe, and also it is safe in breastfeeding women. Mechanical circulatory support. So we have short-term therapies, long-term therapies, and heart transplant. So these are indicated when inotropic support fails, and advanced heart failure therapies in peripartum cardiomyopathy, they also fail. So with short-term therapies, we have intra-aortic balloon pump, intraventricular pump, extracorporeal membrane oxygenation. With long-term ventricular assist device, there is a biventricular assist device that can be offered left ventricular assist device can also be offered. And patients that, if none of these above therapies are beneficial for these patients and the patient still remains symptomatic and is not improving, we can offer them transplant if it is available. So, but with the heart transplant, it has been noted to have poorer outcomes, a high mortality rate, and greater incidence of heart transplant rejection. Prognosis. So around 50 to 80% of women diagnosed with peripartum cardiomyopathy achieve recovery in the left ventricular function. So full recovery is defined as the left ventricular ejection fraction of more or equal to 50%, mostly within 6 months. There has been a significant improvement in the mortality since the early 1970s, when it was reported to be around 80 to 50%. Currently, the overall mortality rate has been estimated to be about 10%. Afro-Caribbean lineage is associated with a reduced likelihood of recovery. So in contrast, peripartum cardiomyopathy associated with hypertension has been associated with more successful recovery. And of note is that patients, as I've mentioned, those that have hypertension, they have been found to not have the genetic mutation of the TTN gene, which might be one of the reasons why they have been found to have a successful recovery. So the poor prognostic factors for patients with peripartum cardiomyopathy is an ejection fraction of less than 30%, severe left ventricular dilatation, and delayed patient that presents later on, which is a delayed diagnosis of the condition. So there was an IPEX study that was done, investigations of pregnancy-associated cardiomyopathy between 2009 and 2012, where they had 100 women with newly diagnosed peripartum cardiomyopathy within the first 13 weeks postpartum, and this study involved 30 centers. So what they did in the study was that they assessed the patient with peripartum cardiomyopathy, and they did an echo at diagnosis, 6 months and also 12 months, depending on their time of enrollment. So the left ventricular ejection fraction at the time of diagnosis is currently the most reliable predictor of adverse outcomes and also long-term recovery. So in this prospective cohort of women with peripartum cardiomyopathy, they were treated with standard heart failure therapy. And the cohort, it consisted of 30% Black women, 65% white, and 5% other. 72% of the women, they were able to achieve complete recovery of their left ventricular ejection fraction. 15% they achieved partial recovery, and 13% of women, they had poor outcomes. And this was the poor outcomes, 6 had major events, and the major events could be multiple ICU admission, intracardiac thrombi, or death. And 6, they had persistent severe cardiomyopathy. So in this IPEX study, the poor prognostic features that were noted was the association of the lower left ventricular ejection fraction at 12 months. And the factors that the patients that had this lower ejection fraction at 12 months, their initial left ventricular ejection fraction was less than 30%. Their left ventricular end dilatation diameter was more than 6 centimeters, and they were of Black race, and they had a delayed presentation that was after 6 weeks postpartum. Subsequent pregnancy. Women who have experienced peripartum cardiomyopathy in an index pregnancy often experience concerns about the safety of a subsequent pregnancy, both in terms of maternal and fetal risk. In the absence of robust data, consultations will often rely on specialist expertise and their experience or very limited data to counsel these moms about the risk of recurrence in the subsequent pregnancy. It is imperative that women are provided with the best possible information in order to make an informed decision about future pregnancies. So there was a study that was done it was systematic review for maternal and fetal outcomes in subsequent pregnancies after peripartum cardiomyopathy. So the objective of this study It was to determine the risk of adverse maternal and fetal outcomes in subsequent pregnancy after the patient has had an index pregnancy that was complicated by peripartum cardiomyopathy. 29 studies were included in the analysis, and in total, 779 women with subsequent pregnancy after peripartum cardiomyopathy results were assessed. So for the primary outcome of the relapse of cardiac failure in the first subsequent pregnancy after peripartum cardiomyopathy that was their primary outcome. And the authors, they used the definition of recovered cardiac function to be an ejection fraction of between 45 to 55% at the onset of the subsequent pregnancy. There were 8 deaths in the 473 women across the included studies. The overall risk of relapse in the first subsequent pregnancy was pooled to be at 32%. Of those patients that have had a recovered cardiac function at the onset of the subsequent pregnancy, the risk of relapse was 24%, and those that had a non-recovered cardiac function at the onset of the subsequent pregnancy, the risk of relapse was 36%. They were unable to create a pooled estimate as studies followed up women at different amounts of times post-delivery, and most of the studies, they were not providing the total length of the follow-up. On the same study, the neonatal and fetal outcomes. So the mean gestational age at birth of all the subsequent pregnancies was 38 weeks gestation. The risk of preterm birth was before 37 weeks was 22%. The risk of preterm birth before 34 weeks was 8%. There were 2 events in the preterm births that were below 28%, which was one was a stillborn and another one was an early neonatal death. There were 3 stillbirths and 4 neonatal deaths. Fetal growth restriction, they had 9% of those fetal outcomes, and small gestational age, they were 17.4%. And the mean weight at delivery, 38 weeks of these babies was 2.9 kg. So in patients that have had a peripartum cardiomyopathy, now with coming with the subsequent pregnancy, this is the recommended echocardiogram schedule. So they need to have an echocardiogram at the on discharge from the initial diagnosis of peripartum cardiomyopathy. They need an echo at the end of the first trimester, an echo at the end of the second trimester, 1 month before delivery, after delivery, and also 1 month after delivery. So this is to assess if there's any worsening of cardiac function and to manage your patient accordingly. Postpartum contraception. A safe and dependable contraceptive is recommended for women with peripartum cardiomyopathy to avoid an unplanned pregnancy. So simple burial methods are not recommended because they are not reliable, with the failure rate as high as 18%. Combined hormonal contraceptive should be avoided because of estrogen and because it increases the risk of thromboembolism, and these patients are already at risk of having thromboembolism. Long-acting reversible contraceptives containing progesterone are safe alternatives, which is Depo-Provera, Implanon, Naristarate. And injectable depot, such as injectable depot medroxyacetates, is less effective and is also considered a second-line option, but it is still quite effective, up to 96%. Intrauterine devices, which is a copper and progesterone-releasing IUD, they are more than 99% effective. They are long-lasting. There is no added risk of thromboembolism. Hospital IUCD insertion is advised in this patient because of the risk of the vasovagal response that may occur if they are out of the hospital setting, which may activate the pathology. Prophylactic antibiotics are currently not recommended, even though there has been comments about the risk of endocarditis in this patient with the IUD. Sterilization options also include vasectomy. The partner can come and you can refer them for vasectomy if the patient is too unstable or if the partner is willing to come for vasectomy. And also for the mother, you can offer tubal ligation, which is 99% effective. So in conclusion, peripartum cardiomyopathy is a rare but serious cause of maternal heart failure. Symptoms often mimic normal pregnancy. Echo is essential for diagnosis. Early MDT management improves outcomes. Careful counseling and future pregnancies about future pregnancies is crucial. Thank you.
Thank you, Nontabeka. That was very comprehensive. We'll take questions or comments regarding the topic, and we apologize for going over time. Yes, Dr. Moray.
Thank you very much for the talk. It was well presented. I've actually got a lot of questions, but maybe the main one is about the bromocriptine, because I think that's seems to have come into your protocol now. You presented the management, and you said for uncomplicated you should give 1 week of bromocriptine. For complicated, you give 8 weeks. You said it like it's a protocol.
Europeans practice that, but Americans are still not keen on using it.
But you presented it. So are you practicing that? Because you didn't actually present any evidence to tell us whether it works or not. And if the Europeans are the ones using it, what evidence did they have, and what population did they use in that evidence? Because you said there are quite a lot of differences between maybe European population and African population. Yeah, so I think there are some concerns with the bromocriptine. Firstly, you said it increases thrombosis. So that by itself is a worrying thing, because one of the complications of this condition is thrombosis. So if you've got a drug which is going to increase thrombosis, then one should be careful about putting it in a protocol unless you've got very strong evidence that it actually improves outcomes, because it might cause complications. Secondly, bromocriptine, it blocks prolactin. So these are pregnant women. Does that mean they're not going to be able to breastfeed? And so we've got to think about the baby as well, because especially in poor communities, if you stop a woman from breastfeeding, then the chance that the baby is going to survive is greatly decreased. So I'm just saying we need to have very clear evidence that it's beneficial before we should be using it. That's my feeling. And you mentioned something called the Rebirth
trial, yeah,
or which is a randomized controlled trial, which is still ongoing.
Yeah.
But it didn't sound like a double-blind trial. You said you're giving rivaroxaban. I'm not sure where this trial has been done, but rivaroxaban is being given to those who receive bromocriptine. Is rivaroxaban evaluated in pregnancy or in around pregnancy?
Outside.
It's outside pregnancy.
Oh, that was postpartum. Okay. But what about the other group? Because isn't this condition prothrombotic anyway? I mean, you can get some cardiac thrombi. So don't you give thromboprophylaxis even to people who are not on bromocriptine? Isn't that
depending on the left ventricular ejection fraction you do.
Yeah. So they're giving to those who would obviously require
Yeah. So anyway, that's I just want to know about whether you are actually using bromocriptine, because I didn't see the evidence to justify that in your presentation. And we get quite a lot of postpartum cardiomyopathy in our practice. I mean, you say it's rare; it's not that rare.
Yeah.
There are even quite a lot of deaths from it if you look at the Saving Mothers report. So there must be a lot of people who survived as well, who didn't die. Do we have good sort of series from our local experience? Because that would be an important thing to do. Yeah.
Yeah, I think that. Communications.
So just I address the bromocriptine
study to have enough evidence locally.
clear. Are we using it? So the answer is yes. According to the experts, we are using it in nursing.
Yes, so according to the European Society,
No,
Truly, we are using the bromocriptine, and in that protocol, we keep bromocriptine. I think that's clear. Is that also?
Even our discussion with the cardiologist, and literally they say if you catch or if you make this diagnosis early enough, then you can give bromocriptine. But it hasn't been a standardized protocol. So we individualize patients. And then we don't have a lot of robust evidence with regards to bromocriptine. Local studies that have been done, they were underpowered. So obviously we'd have to await the rebirth trial, which will only be presented in 2029. Yes, we have to individualize, manage as an MDT, and then we get the guidance from the physicians or the cardiologists regarding the bromocriptine. Obviously, it's not really a contraindication to breastfeeding as much as it suppresses lactation. But the data or the studies that we've looked at, they say they can still breastfeed, even though the the milk production won't be as adequate. So they might have to supplement.
So with regards to the studies that have been done for bromocriptine, I did come across one of the studies. I just can't remember which one it is. But there was evidence of improved left ventricular ejection fraction at by 12 months. But it also depended on quite a few factors, which was the left ventricular ejection fraction at initial diagnosis, the patient's ethnicity, and their presentation, whether it was an earlier or later presentation. And of patients with an ejection fraction that was around 35%, I think more than 35%, there was an improvement of the ejection fraction to more than 65% by 12 months, ejection fraction of 56%. But there was more of white patients. It was not the Black population. So it was actually quite multifactorial. Even though they would be giving bromocriptine, but you would look at other different factors around the patient.
So basically, we don't have evidence.
We don't.
Now,
It's not adequate. Yes, it's not adequate.
so if a cardiologist says use it, you just use it.
You have
Even
to
if they
discuss
think
with the
it's-
patient. You have to offer it to the patient and see what the patient feels and thinks about the drug. And then obviously it has to be in consultation with her.
How will data?
Any other comments or questions? Take one last one.
The one that worried me, especially after one patient was presented from
Mahatma Gandhi.
Mahatma Gandhi, was the use of beta blockers in acute unstable cardiomyopathy. I think yes, beta blockers are of value, especially the selective cardio selective beta blocker. I'm not quite certain whether labetalol is cardio selective or not in terms of story. But in acute state, where it's going to drop the inotropic effect, and I think in that patient the pulse was about 150 or something like that, if I'm not mistaken. And I saw you mentioning a pulse here as part of the acute cardiac failure. So I'm still not very clear whether it is appropriate or inappropriate in that circumstances. My undergraduate training said beta blockers in acute state are not supposed to be used. So I'm not quite sure what your reading said in terms of that kind of situation. I think you mentioned metaphor, whatever the story is, but I think it's something like that. So I'm more worried about, I think because Moran is part of the maternity, whatever stories, I think there have been a few cardiomyopathies that have died, and recently. And that was one of those, and it kept worrying me. So I'm not quite sure whether there's clarity in terms of the in acute state. I mean, you do get cardiomyopathy that comes there. They are in stable situations, but unstable cardiomyopathy is there in light in terms of the vital strategy.
I don't
Difficult for you.
I don't have an answer for you, but we can try and find out.
Yeah, I think we can try and find out. But on the articles that I read, they were mentioning the beta blockers as part of management in the acute phase. But then I will just have to double check. Yes,
Yeah.
yes.
The pulse rate, unstable,
Yes.
is whatever the story is, the unstable
Yes,
acute cardiac failure. You had a slide on
yes,
that.
it is part of it.
Mhm. So it's something that we need to look into. Lauren and you, the provincial people, what was your take?
I think this in the realm of the cardiologist. This is where you have a multidisciplinary team. This is the management of acute life-threatening cardiac failure. So I think we need to be guided by the cardiologists. I don't think it's something that's in the general protocol. It might be in the but it's important because the patient may not be presenting to the tertiary center at the start.
Yeah.
It might be in the district hospital. So, they'll be phoning. We need to know what advice to give them. I think it's an important question.
The last one was the digoxin I asked the last time, and I didn't see it featuring anywhere here.
Yeah, new protocols are not mentioning digoxin. Yeah, and yeah, we actually asked the cardiology guys at Lutuli as well. They don't use it anymore.
This one.
Yes.
Echo is
Yeah.
must be done.
Yes.
So in the days before echo, this was a long. We could diagnose it even before echo. I think before we used to say an additional criteria for diagnosis is if you have an echo, but now you're saying echo is essential. So then my question is, who does echoes? Because there are scan machines everywhere. I think in the near future we'll all have our own personal portable scan machine in our pockets, like stethoscope. You have your echo, your scan machine. So who's supposed to do echoes? Because it seems like in many places difficult to get an echo. If you have a physician, do they do echoes, or can they not do echoes? And should we, as ONG specialists, learn to do echoes, or you as fetal medicine or maternal fetal medicine, should you be doing echoes? Because if it's such an important investigation, and all the time we seem to be relying on echo now, then we should be able to do it. But as obstetrician, even if you're not a fetal maternal specialist, you can do ultrasound. Even medical officers can do ultrasound of the fetus. But can the physicians do echo if you ask them themselves, or do they say, well, no, there's no echo technologists?
They do.
They do. So every physician can do an echo.
Ideally, every physician should be able to do an echo.
Also, in other centers, in ICU, the consultants, some, or depends on their level of experience, they do echo in a patient that went straight to ICU, and with the suspected diagnosis of peripartum cardiomyopathy, they sometimes do a bedside echo there.
All right. Thank you. See you guys next week. Enjoy your weekend.
Yes, it is.